Just 2 weeks ago, we had docs from Atlanta. I've had folks from Nashville, Oklahoma, other places fly in. They spend a day or two with us, and we train them right here at home at Erlanger. Dr. Langs and her leadership, highest volume stone center in Southeast. And her efforts are commendable to develop that over just a very short time. This is the latest technology acquisition. And again, Mr. Coleman's office, I walked in about 6 months ago and I said, Jim, help me out because we are doing a lot of men a lot of harm. And the reason was we learned from women. You go back 20 years ago, any woman that got breast cancer had to have a radical mastectomy, meaning complete breast removal, all sorts of other operations. Now, most women who get breast cancer, they have what's called lumpectomy, just go take the tumor out. For guys, for years, you got prostate cancer, we had no choice but to remove the whole prostate. Because of that, recovery was a lot difficult, a lot of side effects. So Europe developed high intensity frequency ultrasound, which is an ablation device that uses computer and robot model to just find the tumor and a border around it and zap it and leave the whole prostate in place. And that's important because again, it's no cutting, it's done through a ultrasound probe, just like when they do ultrasound on your kidney. Guys go home same day, you got a only downside so far, you got to wear a catheter for a few days. But this I put there as an example, the yellow circle there that you see right there, that's the tumor. And because of the MRI and all, we can pinpoint it. And then you draw a circle around it that says, okay, I'm going to ablate that area, and then I'm no longer cutting on them. I sit at a computer. I feel like a computer programmer. And there are the two screens where we kind of, Philip, see if you can play the left video first. So I don't know if you guys can see, but essentially you map the whole thing and it's completely computer aided based on your MRI, imaging, real time, do the planning, and then click the right one. And you can see that on the right screen, there it is, and when you see that shadow, that's the sound wave going to zap that tissue. And in terms of recovery and outcomes, the beauty of this is it doesn't affect, say 10 years later, someone develops another lesion, you can go back and do the same thing. So what it has done is taken cancer from what I call all or nothing option to where if you got problem in one area, and I use a fruit analogy often, if a corner of a fruit is rotten, if it's a small, you can just remove that area. If the whole fruit is rotten, then you know you have no choice. But at least it gives us options. And again, this is based on nothing but technology. Let's see, let's go to the next slide for some reason. So to sum it up, that's us. And our foundation is we are clinical leaders, meaning we love to take care of complex cases and be comprehensive. We are focused on education. We can't do either of those if we didn't have research and innovation. But at our heart is the idea of service, because that's one of the biggest reasons I joined Erlanger, because in my office, believe it or not, I have homeless people, and I have millionaires and billionaires, and I take care of them the same. And that's why I got into medicine, and working at a university setting at this public institution allowed me to do that. So again, I want to thank you all for your time, attention on a beautiful evening. I won't bore you much. I see some bottles of wine. I see some over there. So thank you. And we couldn't do this without our team. So I have to give plug to Philip Adler, who is our practice leader. He made sure the doors are open, employees are there, and every other thing that we've been on him for. And our entire operating room crew who are there. Friday night, they were with me till 1 in the morning. And they are there, and then they turn around, come back Saturday. So they're committed to service, and I'm only as good as the people around me, including my partners, management, leaders, and people who work with me in the operating room. So thank you again. I'll stop, take any questions you guys have. sir.
You talked a lot about robotics. Do you have a strong radiological practice there? Or?
Yes, so it's our radiologist. Joke is we have a radiologist by name Crawford. We call him Q. And he's a Yankee like me. He's from New York. And the joke is if no one can, Q can. If you can't, no one can. So yes, we have a phenomenal group of radiologists because without them, we can't do it. Even with MRIs and stuff, people come in, they say, oh, I'm going to get an MRI at Jack in a Box place. I say, well, you can get the film, but the read is experience. Those eyes can see what mind doesn't know. And our team, our radiologists, I've worked with them for probably 8 years. And when he calls something, I mean, accuracy. And the other thing is that in our setup, because I'm training younger surgeons, students, I can't BS. I have to be truthful to myself and them. And because of that, we always scrutinize all our data, all our treatment decisions. Everything is board, looked at tumor boards. Bad outcomes are evaluated, how can you do it, which is way different than, and I have friends and colleagues who are in private practice. You can do whatever, the accountability is a lot less. And because of that, we have not just phenomenal radiology department, our radiation department is solid. So again, I'm a cancer guy, so in terms of, there are very few places in the country where you have, under one roof, almost 3,000 plus robotic surgical experience. You have CyberKnife and the state-of-the-art radiation unit. You have a LINAC, focal therapy, HIFU, just in laser experience of almost 2,000 plus cases over so many years under one roof, and that's what brings the other people from outside to come and spend time with us. So that's a good question, but as I said, it's not, and that's why oftentimes, people will say, Singh, you want to go work at this hour? And I tell them, I said, it's not me. I'm one part of the puzzle. I'm only good as the team, so if the radiologist doesn't read the MRI accurately, my biopsy rates are going to be poor. I'm going to be treating the wrong area, and then I'm sitting there, why did it fail? Well, it didn't fail because of what I did necessarily, but the process began much earlier, and that's why I love working at a tertiary center because I know the people who are there, they're vetted and they're solid.
Thank you.
Yes?
On the same note, with radiology, is AI for people that read computers or computers taking over that part, working with a radiologist? In other words, a radiologist, a good one, can read a scan, read a report, but that data is put in. Are computers starting to take that over?
So it's not so much they're taking it over, but they're working more and more in sync. So AI softwares are being developed where they are looking at images and predicting odds, but ultimately the human eye and what I call, there's no substitute for clinical history. So I'll give you an example. I had a patient that got sent to me because somebody said they have kidney cancer. I looked at the scan and I went and I saw the patient. I said, okay, what's going on? He said, Doc, I've had massive fever for the last 2 weeks. The infection and cancer, they both look the same on scan for kidney. I said, I don't think this is cancer. Wait 3 months. Let me get a picture. 3 months later, the read comes back, kidney cancer. I look at the picture, it looks about 50% better than it was 3 months ago. Cancer doesn't get better. Infection does. 6 months later, that person, the kidney look completely normal. So AIs will be there, but they will be vetted. But there are companies out there that are actively working on replacing or at least augmenting how the reads are done in imaging based on AI and repetitive learning. Yes, sir.
Doctor, thank you for coming today. Your colleagues have done a great job. 2 questions. One, you mentioned there are 13 hospitals in the U.S. doing this robotic thing.
No, our fellowship training is with robotic with cancer certification. We're one of 13. Yes, sir.
Thank you. The second one is if we had a surgeon from a hospital that doesn't do robotic and we asked them about robotic, what would they say the downside or risks of robotic are compared to
So-
non-robotic?
So it depends on, it's always, I tell people when folks come to me, they say, Dr. So-and-so said they'll do an open operation. I say to them, go have it done. A good surgeon with a robot is a good surgeon open, is a good surgeon with chopsticks. A hack with a robot is a hack with the open, is a hack with a chopstick. So it's not necessarily, and I've had this conversation with our hospital leaders, that anyone can buy an airplane, but you also need a pilot that can fly. So it's technology is one piece of the equation, but the training also goes, and outcomes also.
Thank you. And being from New York, have you found good pizza down here or what?
Southside Pizza, close to my house, is probably the closest. Yes, ma'am.
Where do you get the training for the robotics?
Where did I get my training? So I would say, got a little bit grandfathered in. It's called being at the right place at the right time. So I was a resident in Syracuse, New York, when robot came. At that time, the money Menon in Henry Ford, Dr. Menon had gone, and he got a donor to give him $7 million back in those days. And they went on a limb and bought 2 robots. And first it went to France and kind of did some training and stuff, and then brought it to Detroit, to Henry Ford. And my chairman had trained in Detroit. So when we were about to get the robot, they said we need one dummy who can be at the side. And I had met all of my case logs to kind of coast for next. So then they sent me for 3 months to Henry Ford in early years. So I went trained there. Then I came back to Syracuse and we built our program. I was there for 2 years. And then I was at NCI, and NCI had just gotten their robot. So I kind of looked like the star amongst the dummies, you know, like they were learning and I knew this much. And then when I came to Chattanooga, we kind of slowly ramped it up. And as a personal journey, I'll tell you, I mean, people say, first prostatectomy I ever did, it took us 12 hours. When I moved to Chattanooga, I was down to about 4 hours, and I was feeling pretty good. Hey, I'm doing better. Now, if it takes me more than 45 minutes to an hour, I'm like, what the heck is wrong today, you know? So, and same thing, the patients were in hospital a lot longer. We didn't know. We didn't have a lot of the tools at our disposal. We didn't have a lot of the technology, like certain sutures and other things. So that's been kind of my journey. When I started here, I'd probably done 200 cases back then, but that was in 2006, 2007. And now, who knows? Yes?
Is the ultrasound still considered experimental? I had a buddy who couldn't get it done because the insurance company wouldn't cover it.
Yep, so early years, the HIFU was done in Mexico and other places where you paid $25,000, $30,000, and I've taken care of a bunch of them. But that was entire gland HIFU on older machines. FDA just cleared this new one about 2 years ago, actually about a year ago. And we were one of the early ones who kind of invested money invested in the technology to get that here, because the focal therapy is no longer considered, it's part of the guidelines. And FDA has cleared it and Medicare pays for it. And you know, usually a lot of you are more familiar with Medicare than I am, but based on what I know, if Medicare starts paying for it, then there is science behind it, otherwise they're not gonna pay for anything experimental. So yes, now insurances cover it, Medicare pays for it, and our patients, the biggest thing that has happened is folks were going and getting some crazy stuff done for HIFU. And that has stopped because now we can actually do it under protocol, what I call under controlled settings, certified places, things like that.
Amar. Hopefully, I'm the last question for Dr. Singh. As the loved one of someone who is a cancer patient, one of the things we did was we studied everything we could, and we found the Bible of prostate cancer by the doctor at Johns Hopkins. I can't remember.
Pat Walsh.
Okay.
Patrick Walsh.
All right, Patrick Walsh. One of the things that, and he's Johns Hopkins, he said was about this issue of finding the right doctor
I'm beyond couple of thousand, so that's it. But that, Amy, that's a good point. So that's not just true in robotic surgery. So, and most of you here are folks who have, I'm sure, studied and know science and read more than I ever do. If you look at any cancer arena we look at, or any major operation, Dr. Lang does stonework. People who do high volume, it's not just about the surgeon. Surgeon is good because they have that much experience, dealt with all the unusual stuff, so on and so forth. But it's also the team. It's the nurses who take care of you when you're asleep. It's the person who looks after you when you wake up. When you go home and you call issues you may have, the experienced team has seen it all probably 50 times in the last month as opposed to inexperienced team. The data on bladder cancer on that, if you're a center that does more than 50 bladders a year, you have better outcome. And it's not just incremental, it's day and night difference, to a point where some of the insurance carriers are now, recently I had a patient who said his insurance said, go to get your bladder removal, you can travel, we'll pay for a hotel, go to see Singh. And I'm like, how? And they said, well, they said you had the volume. So for pancreatic cancer, people have Whipple. You go to small places where they do 1, 2 a month, different outcomes. You go somewhere where they do 3 a week, whole different outcomes. So it's like anything we do. If you go to places where there's a lot of what I call repetition, that's what leads to success. Anything else?
Dr. Singh,
Jim?
basically say
Yes.
a word, just
Yep.